Get it done, make it fun. So, what's going on in this OB? Well, the history, fun stuff. I'm probably not going to ask you a lot of questions about that. It's just kind of nice to see how things have changed. And the big thing with OB is, I'm going to talk fast, all right? The big thing with OB is how we've changed over the years. From family planning to pro-life, pro-choice, even right now in our government and in our society. Not too long ago, I drove down the road over on Peter Street where Planned Parenthood is, and people were out there with signs, and I'm sure you've seen they've had downtown, they've had marches and things for pro-life, against Planned Parenthood. The thing about OB, there's a lot of your own personal beliefs. I won't share mine with you. You might figure it out just by the way I talk. But OB, you have to keep some of your personal philosophies and beliefs to yourself. You have to let the client, the patient, make their own decision. You are, as a nurse, responsible to share information with them and let them make their own decision. You can't be biased whether they want an abortion or not, whether they have 10 kids or not, whether they have no prenatal care when they come in and deliver. You cannot let your emotions and your biases and your feelings about their socioeconomic class, their culture beliefs, their family beliefs, their drug addiction influence the way you care for them. And it's very difficult sometimes when you see a drug-addicted mom come in and deliver a baby, and you look at that baby and you go, oh my God, what was wrong with that person? You can't let those emotions come out. And whether you're educating someone about contraception, what to use, how to do it, whether you're trying to educate about breastfeeding, bottle feeding, you present the facts and try to let the patient make their own decision. There are many times that you may want to try to influence them, especially if someone has no money and they're trying to buy bottles. You can relate to breastfeeding if you know that they can get support, okay? If they can get the right nutrition, if they can get WIC, they can get some things to help, and they're eating properly, then their babies are going to get the right nutrition. If you don't think mom's going to do that, mom's going to be on drugs and stuff, then you're going to have to refer back to formulas. So those kind of decisions is what a nurse has to make, especially you guys, if you're going to work in doctor's offices and things like that and in the community. Okay? So, personal beliefs to the side. Society has changed. We've got single moms, we've got teenage pregnancies. Roanoke was one of the highest areas in the state of Virginia for teenage pregnancies about 5 years ago. We topped Richmond for teenage pregnancies through the Prevention Council and all the education in the city schools. Things have improved drastically. It's down substantially. Obamacare has helped greatly with some individuals not being able to get health care, now having some health care. Even though Obamacare has affected some individuals and made their health care costs go up, some people it's helped, some people it's hurt. But these are the things in society that's helped. Years ago, moms had babies and they stayed for about 3 or 4 days in the hospital. Now, you're gone within 24 hours. So times have changed. We have birthing centers. We don't have too many birthing centers around here, but there are birthing centers where people can go in and have reduced costs as long as there's no trauma and there's no high-risk pregnancies. But the trend years ago was hospital, perfect this, perfect that. Then the trend went to birthing centers. Then the trends went to home births. Then the trends are back now to hospitals, okay? Because as more women become educated, they are the ones that want to have the facilities if needed because they understand the complications of a delivery. Most deliveries are fine, but there's 1 in 100 or 1 in 200 where there's complications. Midwives, doulas. Have you ever heard the word doula? Midwives and doulas are a big thing. Jacoby, you do not have to remember all this. Okay, now you need to read it and kind of put it in your brain because your NCLEX may have certain doctors' names on it because they are the ones that influence the change in our health care. Family-centered care is the term that's used. That is the norm. Husbands at birth, this is where the LDR, the LDRPs, mother and baby together. Remember years ago, it was like mom and baby stayed in nursery. and you didn't see baby except brought out to be fed. Baby stayed in nursery. Mom got to rest. Now we don't have true nurseries anymore. Babies, they want babies to stay in the room because they want mom to realize when you go home, you have to know how to care for that crying kid. You got to realize you're not going to be able to sleep a full 8 hours while someone's taking care of your baby in the nursery. So they're trying to make it more realistic for moms when they go home. So nurseries are for assessments and treatments. Otherwise, they really like for the babies to be with the moms now. And I'm not talking someone who wants rooming in. I'm talking about everybody. They want the babies to be with the moms now. Children became a big part in all of this change over the years. You know, we found out that children were lacking, and when we started developing more PEDS programs, we realized with immunization and care what children needed, you know, like cuddling and holding for psychological development, things like that. Let me catch up with my notes real quick. The 1900s is where that twilight sleep was introduced. That's when everybody went to the hospital to have a baby, and their mom was given scopolamine, and she was out. She was out. Then in the 1850s is when we started becoming concerned about children's care. We realized that if we boiled milk, there was less diarrhea. We realized that we can pick children up. It used to be you'd mommy wrap them and not pick them up because you didn't want to give them infections. You didn't want to spread germs. And then we learned that midwives had less problems postpartum if they were the ones who delivered than physicians. So people started doing research back in the 1900s and go, why does a midwife have less infection than a physician? Guess why? Hand washing. Basic things like that. So this started making us identify that what we needed to do to improve this care. In the 30s, you know, stimulation, isolation of babies was a problem, and they realized that we need to have bonding. That was a big word. In the 70s is when the hospitals started. That's when Jacoby, he's the father of PEDS. That's when they started saying that we need playrooms in hospitals. So in the 70s, this is my generation, we developed all these playrooms for kids when they were sick because we had tonsils and broken bones and asthma. You know, we had everything that stayed in the hospital. So we had playrooms for them. Then a few years later, we realized those playrooms were nothing but a source of contamination and infection. Then as we realized we don't need to keep kids in the hospital, we need to have kids on outpatient, and only the very sick kids in the hospital, we didn't need as many playrooms. So you'll notice that certain things have changed over the years. Hospitals used to have a big old playroom for kids that went in, and then things have kind of settled back where you may have like a foyer or a lobby area where kids getting closer to discharge can go out and play PlayStation, things like that with their friends. So we've changed over the years. We've evolved to regional care. We can't have delivery of OB everywhere. Like in Franklin County, they don't deliver babies down there anymore. Okay, they used to, so that they try to specialize because you don't do enough to keep skilled. That's the same way with a lot of other rural hospitals, the same way with PEDS care. You know, there's certain things that we can take care of here at Carilion, and there's certain things that have to go to UVA or to a specialized center down to Wake Forest, wherever.
So regionalized care is just having that one place
Where you refer to.
Okay.
Mm-hmm. Mm-hmm. And that's where a lot of the high risks, and so, see, that comes into another problem. If you think about, a lot of this stuff we're talking about right now is common sense. If you think about it, if mom has to go to a regionalized care, she has no family support. If she's already got 3 kids at home, who's going to keep her kids? Is her husband going to stay home? Is her husband going to go with her? Does she have to go by herself? Whether it's her or whether it's her neonate that has to go. So we've got concerns about the social aspects when you have regionalization. It used to be we want to keep everything in our community. But then we realized high-tech, cost of healthcare, you couldn't. So we went back to regionalization. But then we kind of neglect that social part that families need when they're sick. So Ronald McDonald houses were built. Things like that for family members to stay in. And to be honest, within the next 10 years, we're going to see more changes in healthcare. You know, there's research now that we're doing surgery in utero. So babies that are identified that have cardiac problems, we can do actual surgeries while they're still in the uterus to correct that cardiac issue, some of those valve issues. Bioethical issues, this is a big, big thing, and this is a part that what I was kind of talking about at the beginning. See, I'm just kind of like running through these. You all can kind of follow along with your PowerPoints. Talking about regionalization, traumatic for families. These bioethical issues are where, when we have an amniocentesis and we find out that a baby has Downs, and depending on how far along mom is, some women may opt to have an abortion because they don't want to bring a child into this world that may have certain abnormalities, certain medical conditions. They may have other children with that problem and they've already experienced, or they may have friends with it, or it may just be their personal belief. Or they may want that child and realize all the problems. So when we're talking about bioethics, we're talking about prenatal screening, we're talking about genetics, we're talking about having discussions with families, we're talking about that Human Genome Project where we can identify who are carriers of certain diseases, whether you want children or not. It gives you some prediction. We're even talking about in this Genome Project whether, well, I want a girl, I don't want a boy, where we try to control the genetics, and I want a blonde-haired, blue-eyed little kid, where people are trying to control what they have. So this is, a lot of us will have different beliefs about that. Some of it is very strange to us, but there's research going on out there, even on intelligence levels of children being born that have certain characteristics. I want them musically inclined. I want them to be able to be a smart in math. I want them this. So just like, we've cloned sheep, guess what? We're cloning animals, correct? Other than sheep now. So you have your own beliefs about this. Surrogate moms, you may have some beliefs about this. Can grandma have a baby for me because I can't have children? She's in her 50s and she's the surrogate. Or you have opted and made a contract with someone to have your baby for you. These kind of things. I've already talked about an amniocentesis, making decisions for the continuation of a pregnancy. One thing is about when you have a surrogate is, whose sperm are we using? Are we using dad's sperm, or are we using a sperm bank? Do we use mom's egg, or did we use the surrogate's egg? See all these ethical questions that can come up? And then at the end, whose baby is it? Is it mom who gave the egg and sperm and this lady was just a carrier? Or did this lady donate an egg, so it's half her baby? The cost, who pays for what? This is kind of a big ethical dilemma, isn't it? And we could probably have hours of discussion about this. And our generation may feel totally different about this than your parents. And in a few years, your kids may have totally different feelings about these ethical issues as healthcare changes. It just gives you something to kind of think about out there. Those individuals who are living in poverty, are they getting the right health care that they need? Some of this goes into the effects on the children if they have not received prenatal care, or if mom is a heroin addict, or she's still using drugs, or she's an AIDS victim. How does that affect the long-term care of the infant? Have we identified them and try to get this child out of that environment, or can we start preventative care with that child early? And then all of this kind of goes back to cost containment, healthcare costs. Who pays for this baby who was born to a individual who, due to their circumstances, did not receive appropriate prenatal care? Who's taking care of this baby in the neonatal intensive care when their electric bill, their neonatal hospital costs can exceed $350,000 to $500,000? Who's going to pay for all that technology that this individual received? So hospitals have to look at that. In your tertiary care center, you have the ability to receive certain funding to help for that, but that's why regionalization became important. Not every hospital could afford this, could they? Someone having a bill of $350,000 and not being able to pay. So poverty is going to influence your peds and your maternity care. Okay. what mom gets and what baby gets after. The demographics of where people live. If I live out in Bedford and all of a sudden I go into labor, do I go to Roanoke? Do I go to Lynchburg? If I live way out in Franklin County at the Henry County line, where do I want to go for my health care? Do I go south? Do I come to Roanoke? So these are things that when you're dealing in your outpatient clinics with patients, these are things that you have to deal with to try to help them let them make the decision. I'm sure we're all aware of PPOs, right? Some of you probably have HMOs or PPOs in your own health care that you have. Managed care, putting caps on care, cost sharing and cost shifting. Do y'all know what that means? Cost sharing and cost shifting. Did anybody's insurance premiums go up?
Yeah. And I just learned that that's why it went up. Because I read it in the book.
You don't think about those things.
No.
You just thought it was the cost of doing business for Aetna or Blue Cross
Right,
or whoever.
it's covering the ones who don't have coverage.
Amen. Mm-hmm. So these are things that affect, depending on your socioeconomic class. This affects people's morality and part of the problems that we have in the United States today. Because, those that are in the upper economic class, it's not so much an issue for them. But those people who are struggling and now have to end up paying $800, $900 a month health care, that's a big chunk.
Wait, so if you have your insurance, and like, let's say Tammy has insurance and I don't have insurance, hers is going up because I don't have insurance?
Right, because of the Medicaid. Like if you go on Medicaid or somebody has to absorb that cost.
Somebody has to absorb the cost.
And
So
that's
it's called
us.
cost shifting. So the premiums going up, not just because the hospitals are charging more, that is part of it. Part of it is that technology's gone up and all these different companies are charging more for hospitals to buy equipment and farm charges and all that. But part of it is to cover the uninsured or under Obamacare, those individuals who have very low premiums. This is the cost shifting going in that. So this is part of things that a lot of people don't realize. That's why some people are very upset with Obamacare. Some people are very happy with Obamacare. It depends on where you are in that spectrum and how much it affected you. I have a friend who's single worker, owns a business. Her insurance just for herself, she has no medical problems, is $1,000 now. It went up from $800 to $1,000
A month. Yeah.
She's like, she's a hairdresser. She goes, I don't make that much. What do? I gotta have health care. And she was with, I think, I don't remember which one. She was with Travelers or United Health. I don't remember who she was with. I don't want to badmouth any health insurance company. I don't remember which one it was.
Some of the things I thought were really good that Obamacare did, like, I worked in a pharmacy, maybe that's where you saw me. I worked for CVS, I was a technician for CVS.
That's it.
And, there was young girls that came in there that just had coverage for birth control. That's all they had coverage for. And that's good, because in the long run, really, that'll save us money.
Right.
So I agree with, things like that, but other things, maybe not so much.
I don't know. I guess where I'm still on my mom's insurance plan. When I read this part of this chapter, I was so lost that I don't, understand insurance whatsoever.
I think it's complex.
It is very
Yeah.
complex, and a lot of times people don't have all the facts. So that's why it gets emotional.
And you'll hear a lot of hate about it, and a lot of just, you'll see someone and just assume, oh, I'm paying for their health insurance while they're doing this and that and the other and not, and so you'll hear that, and that's, I guess, what you mean by trying not to carry that yourself.
Right. You have to kind of put the mask on and not let your personal beliefs influence the way you interact with your patients.
So, as a nurse, when we're talking about costs, when we're talking about cost of everything to the patient who doesn't have insurance, that's what we would do. We would just explain everything.
Give them you just don't, you try to keep your biases out of it. You may say, oh my God, why am I paying, I'm just hypothetically, why am I paying for this person to come in here and have this luxury LDRP room? Why couldn't someone have made her have a sterilization years ago? I've heard people make comments like that. Oh, I don't want to pay for that person to have 6 kids. I'm paying for her 6 kids and I can't pay for my kids. medicines, okay? And she's got 6 kids, she's on welfare, they're getting WIC, they're getting. So this is what creates the moral issues that inflame people in our society. So as nurses, you can't get involved in those moral issues, right? When you're taking care of a client, that's where you have to take that off. You may believe, oh my gosh, I wish they would sterilize her. Yes, so she's been in here 5 times, now it's 5th kid, she's 22 years old. You may go, you can't do that. This is where you have to just present the facts to mom. Maybe at home in private with your family, you have your own personal beliefs. But when you're acting as a nurse, you've got to kind of keep your biases to yourself. But explaining nurses' roles in society now are health promotion and helping to manage care. So you try to educate your patients to make sure they know how to stay healthy. So they're out of the hospital. You know, you may have a discussion with a young mom about immunizations. You know, some people really, there was this time they felt that immunizations caused autism. And nobody wanted, remember in California, that community? And then we had this big outbreak of measles, remember? Okay? So those kind of things, you have to educate and explain to them, well, if you choose not to do this, these may be the consequences for your child. If you choose to smoke while you're pregnant, then these are the consequences. You're going to have a baby of a low birth weight. You're going to have a baby that has respiratory problems. You're going to have a baby that could end up with learning disabilities. So you present the facts. You can't make her stop smoking or stop drinking alcohol, but you present the facts. This is what can happen. These are the consequences. So that's why health promotion is very important, educating the public, to keep them on the right track, to keep them out of the hospital, to try to keep healthcare costs down. And that's how you manage their care. In case management, and you've seen that in hospitals, right? Case managers who are making sure that these tests are done in a timely fashion, that these doctors are seeing, that someone's length of stay is not longer. You'll probably see it more in the hospital setting than you all see it in an outpatient arena. But in a hospital setting, that case manager is making sure they get in, get all the tests, all the doctors, and get out. You know, 3 days, let's get it all done instead of lingering you over the weekend because no one's seen you and you're here for 3 more days when we should have had you out on Friday, but now you've got to stay till Monday. That's increasing their health care costs. So you've got people managing people's care. Then you've got, sometimes it's called critical paths. Sometimes it's called protocols. It's different things in different organizations to keep everything on track. Like now with sepsis, if someone comes in and they have certain symptoms, bam, you start sepsis protocol, right? So this is what it's important for the nurse. Stay on top of the patient's problems, calling them up. If you work in public health or in clinics, call them up. You didn't make your appointment today. What's going on? Because if they don't come in and the baby gets sick, then the baby goes to the hospital. I used to follow a family, and they would never bring this infant in, and this infant had, oh my God, diaper rash that you all can't imagine. It looked like burns over most of their inner thighs, their buttocks. It was so bad. Mom was on drugs. Mom would leave the diaper on for 24 hours. No one changed the baby's diaper. The skin was eaten away, and you didn't come today. Okay, we're coming to your house. We had to have protocols that we established with this family. Finally, the baby was taken away because mom could not take care of the child. Okay? Things like that.
As a nurse, though, dealing with that and like doing stuff like that, isn't that like neglect, right?
Yeah.
And
yeah.
you would report that?
Yeah. Oh, yeah.
Okay.
That goes through social services, and that's, yes.
Okay.
But you can't flip out on them all, and that's a lot of control.
Yeah.
So
You have to stay calm and present the facts.
And follow those
Now,
steps.
would
Yes.
you tell them
So
all
that the
you
right thing
reported? Or like, or you?
In my day, we did. I think now they're a little bit more cautious about how there's protocols.
Okay.
But in my day, we were very upfront, and we would go right in with the social worker and the police and take the baby right then and there, bam, bam, bam.
I know
But
at
today
the
it's a little different.
I know at the hospital, if you bring in a kid, like my niece, she like sprained her arm. A social worker was automatically right there. I was just like, woo, that was fast. Like, she just
Certain
failed.
things, yeah.
It was really crazy.
So we do have the thing called CHIP, with this child health insurance program for families. This was established under state legislature years and years and years ago to try to help families provide, low-income families to have assistance for their some kind of insurance plan for the newborns. So there's CHIP, which you need to know, okay?
And what's it, child what?
Child Health Insurance Program, which is a very, very good thing, okay? There's some support under the Social Security Act also that helps children, and a lot of this is preventative and health maintenance. Get them to the doctor, get their physicals, get their immunizations, make sure that they're on track for their growth and development. Then we have WIC, and that's the Supplemental Nutrition Program for women, infants, and children. And again, it subsidizes low-income families just to make sure that we have proper nutrition for growth and development. And social services helps with all these. Not necessarily a nurse is going to go out and do this unless you work in a very small rural clinic, and then you might be involved in this, but a lot of your social services, your social workers help with these things. But you need to be aware of them. You know, there's Shriners Hospital for Children you see advertised on TV, which does excellent work for orthopedic and abnormalities, structural abnormalities of children. And most of their services are free, guys, if you can get to one of the agencies. Easter seals to help children that have other more severe developmental disabilities, cerebral palsy children. There's even now an out branch for diabetes for children. Children who need, rehab, extensive rehab for growth and development in their musculature. I'm sorry about the pounding. When we get over to the statistics part, you need to understand what mortality and morbidity is. I'm not going to ask you to quote 15.5 deaths per 100 births. I'm not going to ask you a question like that. I'm not, but you need to know what mortality and means when we're talking about an infant or a mother. And let me just look at my notes. Okay, hang on a second. Making sure I didn't forget anything. One word I didn't say a minute ago. An O word used to be utilization review. Remember that term? The term now is case manager when you're in the hospital. Everybody knows what a case manager is in the hospital, right? Okay. We did. Other things that when you're looking at alternatives for parents is, local food pantries. All right, like the food banks in town, the local food pantries. There are a lot of resources that if you get with the social services or the social worker, they can guide you. There's money if children are diagnosed with anemia or certain problems, babies are underweight. There are certain services that are already built in the system out there to help these people. I'm not up to date on all of them right now, but there are many resources available out there. Okay, the CDC is the one that monitors all the statistical data, about mortality, death rates of fetuses, of neonates, of infants, and maternal. And an infant is usually considered a living being up to 12 months of life, okay? So if we talk about infant mortality, we're talking a baby up to 12 months, okay? And so that would include children that may have SIDS, low birth weight, any problems with nutrition, any things that comes along with that, babies born of mom with HIV, all those would be included in that kind of study. The World Health Organization also looks at infectious disease processes like polio, diphtheria, measles, mumps, rubella, whooping cough. That was on the rise again because people are not getting their children immunized. And I know y'all have seen that commercial on TV where the grandparents look like wolves. Okay. There are even studies now out there that are tracking their obesity in children and peds. And Ms. Hayward can go over most of that. But these are things that we kind of track. Low birth weight, whether this was a relationship to non-existent prenatal care, was finances involved with it, what part of the country is it happening in, is it happening in the South, in the North, in the West, what states have a higher incidence of this versus other states. So you can go to the CDC and you can find this kind of data if you ever need to do research on where mortality rates are the highest and what are some of the causes. Does that make sense? And just remember that morbidity, though, refers to a person's afflicted with some type of disease in a specific population. So if we're looking at morbidity, we may be talking about overweight in children. We may be talking about children of HIV. We may be talking about children born with diabetes or cystic fibrosis or learning disabilities or ADHD, things like that. We're reporting that in relationship to mom's health. A lot of the developmental problems that children face are learning disabilities, emotional health behavior problems, speech and vision, respiratory, and we even record now teenage suicide and teenage alcohol, that kind of data. So all of this is included in any of this data that the CDC kind of keeps. You know, part of this helped in developing SIDS. So how do babies sleep now?
On the back.
On the back. We don't put babies on their bellies anymore, okay? That came out of part of these studies that they found out. These babies were dying. These babies were dying. So why were these babies dying? They also found out, you know, cigarette smoking, low birth weight babies. Why were all these babies having low birth weight? Have you heard of the Healthy Plan 2020? The 2020 Healthy Plan was where it's from the National Institutes of Health, it's from the federal government. It started in 2000, it went to 2010, and now the plan that we're in right now is the 2020 plan, and it's to promote wellness, and that's for us, everybody, to limit disabilities and try to decrease substance abuse. So that's why we as nurses have a very big role in counseling and advising and resources. That's why there's school nurses were placed into the school systems, even though some schools have had to cut back on it because of cuts in the budget. But school nurses, that was the big thing that drove the issue of school nurses. More nurses in the public health system, getting more nurse practitioners out in rural areas, you know, getting the CHIP and all those things. The CHIP and all that started way before then. That was back in the 60s and 70s. We had CHIP and all that. But the 2020 plan it promotes breastfeeding, because babies that are found to breastfeed do better than babies that are on bottle fed when it comes to respiratory problems and immunizations and less colds when they go to school. So the 2020 plan is very important. It's called Healthy People 2020. And I know you'll see that word on your NCLEX. Healthy People 2020. And it involved all these organizations to work on health promotion and prevention, limit disparity between the different economic groups, and decrease substance abuse in our society. That was the goal of the 2020 plan. Does that make sense? And if you ever want to look this up, I'm not going to be real big on going into these infant mortality and things like that. You do need to know CHIP, you do need to know WIC, okay? And I think by this semester, you guys know what you need to do as a nurse. Your big role is patient ed, patient advocate, patient teaching. And knowing that there are nurses in advanced roles out there, there are nurses that have gone on and got their master's, nurse practitioners that work in all these different types of clinics. It's not just an MD, okay? You've got pediatric nurse practitioners, we already talked about school nurses, home health, things like that. I am not going to go over the nursing process. By now, if you all don't know it, God help us. Okay? So you should know the nursing process. I don't need to go over documentation, correct? You guys are documenting, you've been documenting for the last semester in the legal records in the hospital. In your clinicals, you know how important documentation is. I'm not going to review that. All right, that's the first chapter. Now we'll take a 5-minute break. And I'm moving right on, guys.